Yes, sir, we are live now.
So shall I start?
Yeah.
So good evening, doctors and all the participants. I Shuman on behalf of Shield Healthcare, welcoming you all in today's very interesting session from International Human Embryology Research Academy, that is IHRA, in association with Shield Connect. And the theme of the program is 3M of sperm, that is million count, motility, and morphology. So it's time to introduce our coordinators of the session, Nidhi Singh Madam. First, I would like to introduce Dr. Nidhi Singh Madam. She is a senior clinical embryologist, Panacea Hospital, Varanasi, and assistant professor, Bayer, Varanasi. She has more than 16 years of teaching experience and many international publications, and she is a team member of IHRA. So next, Saidi. Yes, now Ms. Yashwita Tanwar, Madam is the clinical embryologist with more than 9 years of experience, and she worked as a senior embryology and lab in Church and New Life India Fertility Clinic Private Limited, and she is the ASRM certified clinical embryologist. And last but not least, Nancy Sharma, Madam. She is the chief embryologist and a lab manager at Department of Reproductive Medicine. And she is also an ASRM certified embryologist, embryo and blastocyst biopsy training workshop she did from Embryology and PGD Academy UCL, and embryology certification course from Indian Fertility Society. And apart from that, she has more than 8 years of experience in the field of ART. And in terms of publications, she has many publications in peer-reviewed journal, and she was also attended many academic initiatives as well, apart from many other conferences. So with this short introduction of the coordinators, I would like to request Dr. Nidhi Singh Madam to take over the session and for further proceedings. And meanwhile, I request all the participants for your active participation, and please drop your queries, if any, in the chat box of this page, so that all will be addressed in due course. So thank you very much, sir, and all the dignitaries, faculties to start this, conduct this program on Shield Collect platform. And over to you, Nidhi Madam, for further proceedings. Thank you very much.
A warm good evening to all.
Nidhi, sorry.
Yes, sir.
Selvam is here. He's there.
He's there, sir? Okay, sir.
Yeah, he's Selvam. Yeah. Selvam, can you please on your video? Selvam. Yeah, he is there. He's there.
Okay, sir.
Okay.
So I'll begin again, sir.
Yeah, please.
A warm welcome to all of you. As 28th January marks the birth anniversary of Lala Lajpat Rai, the Lion of Punjab, who fought for our freedom of life, a freedom to grow, and a freedom to learn. So with keeping the same motto, that is the motto of knowledge to all, we bring you another webinar on the 3 M's of sperm: the millennial count, the motility, and the morphology. So I would like to welcome and introduce our founder, Dr. Ved Prakash, sir. Can I have a CV? Sir is the lab director at Southern Fertility and IVF Delhi NCR. He is the founder of IHRA, past president of ACE India 2022-2020. He is a member of Virtual Education Committee, Society for the Study of Reproduction from 2021-23, faculty at Fellowship in ART Amethi, and as visiting in MSc ART Mysore University. Sir has many chapters contributed, and the area of interest is in vivo to blastocyst formation and innovation in embryo culture system. Welcome, sir. Our co-founder, sir, I would like to invite Dr. Professor Sanjay Shukla, sir. Sir is MSc PhD. He is a senior consultant and clinical embryologist. He is a professor at Clinical Embryology Department of Reproductive Medicine and Surgery at Mahatma Gandhi University, Medical Sciences and Technology, Jaipur. He has been working in the field since 1998. He is currently the president of ACE India and the chairman of the academic wing of ACE India. He is the editorial advisor and former editor of ACE newsletter. Welcome, sir. I would like to invite and welcome Dr. Charudar Joshi, sir. Sir is MSc PhD CRT Belgium. Sir has done his post-graduation in 1993. He has done special training in ICSI IVF from Belgium in 2001, in Singapore in 2004. From Belgium, he has done laser-assisted hatching in 2006, PGD training from Germany in 2008, has donated in doctorate in life sciences since 2018, He's the executive committee member of MPSR chapter and MP IFES chapter. Sir is the past vice president of ACE India and the past president of ACE 2014-16. He is currently the medical director of Genes India ART Bank. Welcome, sir. Now I would like to invite Dr. Ved Prakash, sir, few words of encouragement and to start the session, sir.
Thank you, Nidhi. Thank you so much. First of all, I would like to say sorry. There was some technical glitch with our first speaker, Salvam. So we got some delay because of that. So now, without delaying anything, we are going to start our first lecture. It is on importance of 3M in semen analysis to make the decision in IVF. As you know, the most of the time we are in IVF lab, we are doing semen analysis and just checking count is okay and everything is okay. We just go without taking anything in consideration, motility and everything. Just see the sperm is motile, 1 or 2 sperm is moving. We are doing simply ICSI or sometime not taking everything in account to make the decision, and straightway go to ICSI sometime. But we have to take care of all the things because nowadays there are so many techniques are available on the basis of you can decide how to go about and how to decide the ART procedure, which procedure is best for the patient. So for that we have first speaker, Dr. Salvam Ayarpadi. Can you please see me? Yeah, please. Dr. Salvam Ayarpadikanan is MSc, PhD and postdoc, and his designation is Senior Embryologist in Kraft Hospital and Research Center, Kerala. Worked in Aishwarya Fertility Center, FemLife Fertility Foundation, Apollo Fertility Center, and he has done multiple international publication and 40 conference proceedings, 4 patent in his credit, and 2 of the publications cited in Nature journals. He is a recipient of Brain Korea 21st Century Fellowship for PhD, recipient of Brain Korea Fellowship Program for leading universities and students, and worked as a researcher in Council of Scientific and Industrial Research, worked as a researcher at Department of Atomic Energy. Over to Dr. Salvam Ayarpadi. Dr. Salvam, you have to share your screen.
Good afternoon, everyone.
Sir, last slide is visible, sir.
Yeah, okay, just a second. Good afternoon, everyone. I'm really sorry for the technical problem in the beginning. I'm sorry for your precious time. And we go to the actual discussion today. The importance of 3M in semen analysis to make the decision in IVF. There are so many literatures or saying comparing the motility count, million count morphology to compare what is the actual assisted reproductive technology technique, IUI, IVF or ICSI can be used for particular semen parameter. Am I audible?
Yes,
Yes, sir.
you
Yes,
are
sir.
audible.
Okay. So, for any treatment in IVF in ART, the first thing for male side is a semen analysis. And first, the patient comes to the clinic, we do semen analysis. Based on that, we take the steps from the male factor side. So the semen analysis is the gold standard for fertility evaluation in so far. So ART is divided into level 1 and 2. One is for IUI, and 2 and 3 actually compared to IVF and ICSI. So decision making in these between these three treatments is a really subjective thing. It involves so many factors, so many conditions to be considered. And first level, which is IUI, in NICE guidelines for the indications for IUI or difficulty in sexual intercourse, sexological issues, sexually transmitted diseases, infections, or HIV, or donor insemination cycles, or these are indications for IUI according to NICE guidelines. In Italian guidelines also adds mild to moderate male infertility may be considered as IUI, and in some extent idiopathic infertility also can be with normozoospermia can be criteria for IUI. And in the recent review, it is mentioned that in this paper actually it is mentioned that the total motility cutoff so far the review says that is 30% in ejaculate, and total motile count should be 5 to 10 million at least, and morphology should be 5%. In fact, WHO manual, according to WHO manual, it says 4 is the strict criteria for even normal conception. Still, the IUI, according to the literature, the IUI success seems to be 5 is the best cutoff for IUI. And in addition to that, inseminating motile count should be at least 0.8 to 5 million per ml. It is the post-wash count, should be like that. And recently, one report says that live birth rate after IUI can be good if more than 30 million motile sperms are there in the ejaculate. And second level is IVF and ICSI. So minimum criteria for IVF is 0.2 to 1 million. Morphology should be 5 to 5.5%. And actually, this is second one is ICSI. It's a typing mistake. So cutoff should be 5.5% of normal sperms. It is actually, as you know, for ICSI we less consider motility. Main thing is morphology. In case of azoospermia, we need to have additional extraction procedures like PISA, TISA, MESA, and micro TISA, all these things. And this paper clearly describes many things like minimum criteria for IUI, IVF, and ICSI. Total IMC cutoff should be 1 million for IUI, and for IVF it is 0.2 to 1 million. Of course, for ICSI, anyway we are picking single sperms and doing ICSI, so it is not given compared in that. And total motility should be 30% for IUI and 5% typical forms for IVF. And morphology should be 5%. And here, here is 5% morphology, and here is also 5%. In morphology base, there is no much difference for IUI and IVF, as we need actual good fertilization here. IVF and IUI mostly like natural fertilization only, natural selection only. So, and then in addition, cutoff for IUI is 0.8 to 5 million in IUI. In fact, IVF we will adjust to maximum level possible to reach according to the lab standards. We will calculate the final concentration to inseminate, and depends on the number of oocytes also. We need to inseminate based on that. Any indications for these? And of course, we are not dealing with indications and all in this talk. So we'll minimize with the sperm parameters in this table. And there is another interesting article says, and clearly having some decision-making approach for this is if according to Hanault et al., if we have more than 30%, then they can wait for little 6 months, and if not pregnant, then they can go for stimulation IUI. And in case less than 30 and greater than 10 million, then they directly go for IUI treatment. And if it is less than 10 million, then they will go for IVF treatment. And in this case also, if IUI is not working, in these conditions, follicle size things should be tried, and then they can, if that fails, then they, if not pregnant in this, then they will come for IVF treatment. And selection in this article, the researchers compared many different conditions: high motility, low density, high motility, intermediate density, high motility, high density, low motility, and low density. This variety of factors they considered and compared the treatment cycles, how much fertilization happens, and cleavage things, all they compared. And from that, they concluded that, then in another paper, the post-wash threshold should be 25 million at least, and it gives, when they have 25 million TMC, they had 70% fertilization in IVF patients. If this is comparable for the ICSI, similar to ICSI results. Then in that paper also, they suggested that the pre-wash and post-wash parameters of total count can be used to make decisions, like not only from ejaculate, but also after post-wash, we can check the count and then decide the IUI or IVF, like that they concluded. And this is quite old paper, 1995 it came, and still a lot of good points are there. And that they suggested that at least 10 million per ml, and at least 30% are motile, and among that 15% at least progressive motile sperm should be there for the IVF treatment, and minimum of 20% of should be normal morphology in that time. And then there is another research also compared the ICSI cycles and IVF cycles based on the semen parameters, and they also suggested in sperm motility, they concluded that the sperm motility is the best male parameter to predict in IVF decision, and morphology should be the criteria for ICSI, like that they concluded. And in general, if we categorize these things, for IUI, the sperm motility ejaculate should be greater than or equal to 30%. When they had that percentage of motility, they had the pregnancy rate of 74. When it is less than 30, it reduced. The pregnancy rate is reduced. And higher progressive rate, progressive motility also important in that IUI, when we go for IUI. And mostly the criteria in previous papers, they said 5%, and in general overall comparing with the WHO manual also, we at least 4% we can consider as a morphology criteria for IUI. And if it is less, then the fertility is the fertilization is reduced. Then when the processed sample, and at least 10 million should be there, and survival of 70% should be there after 24 hours. And when that criteria is there, then the pregnancy was fertilization, and pregnancy was fertilization was 94%. When it is reduced, when it is not matching that criteria, it reduced. Then for ICSI or IVF, the sperm can be compared good, medium, and poor sperm relative to their parameters, to motile and motility, count, and morphology. Generally, the concentration of sperm should be 1 million to 1 lakh to 1.5 lakhs like for example, if I say in million, 0.1 to 0.15 per ml motile, and morphologically it should be all should be normal for IUI treatment. If it is for IUI and both IVF as well, and for if they are not meeting these criteria, then it automatically goes to ICSI decision only. If sperm quality is poor in the beginning itself, then if we can it cannot be improved by processing someone washing and all, then we directly go for ICSI only. And this is the one of the textbook shows how we can make the decisions when there are less than 6 oocytes. We can go for and we compare previous pregnancy with the same thing, or if we go then we go for sperm quality. If it is good in conventional IVF, medium means then we go IVF or split ICSI, or if it is poor, we go directly to ICSI. So this in detail if we can discuss, but short of time, we'll go with the main points. Then if previous non-ICSI pregnancy, they had a previous non-ICSI pregnancy, then we can consider for IVF those parameters, even though they are not perfectly meeting or borderline, then we can consider for IVF. And gives then if the question whether they are not patient previously had non-ICSI pregnancy gives an indication for sperm oocyte interaction. There is an issue in sperm oocyte interaction. If that is the case, then we have to go for the sperm has the no ability to attach to the oocyte and make the fertilization. So we have to go for actually if they had a pregnancy, then they have the potential to fertilize. So then in that case we have to consider for IVF. Okay? If it is not there, then we can go for ICSI. And if they had then if they had multiple cycles, we can compare the previous cycle, whether they responded poorly or whether previous cycle history. Based on that, we can go for IVF or split IVF plus ICSI or ICSI based on the previous cycle history. And the number of oocyte also we can based on the number of oocytes we can do split or IVF or split ICSI with IVF. And even if we go for ICSI, there are so many difficult scenarios to get the sperms. There may be high debris, dead sperm, round cells, abnormal forms. Then we go for these are all sperm processing techniques. Just wanted to compare what are all the things we can use, but these are all for ICSI for obtaining the best sperm possible to get the better fertilization and live birth rate. In conclusion, from all the literature so far, for IUI, the cutoff should be 30% motility cutoff, and total motile count should be 5 to 10 million, and morphology should be 5% in normal states cutoff. But while comparing our WHO standards, 4% also we can consider for IUI. And most importantly, the insemination motile count, that is post-wash count. We have to, even if the ejaculate count is little here and there, the final, the wash after post-wash count, we have to make sure it is lying in the 0.8 between 0.8 to 5 million count. And for IVF, this the TMC, total motile count, may be 0.2 to 1 million, and morphology should be same like 4%, even though the latest literature says 5 to 5.5% is required. And for ICSI, mostly the morphology is the maximum criteria, the best, the important criteria, which we need to, according to literature, it says 5.5, but comparing WHO standard and all, we can go for less than, actually it's less than 5 point. If it is less than 5 point or less than 4, then we go for ICSI. In fact, we compare the morphology through inverted microscope, and then we are selecting the best possible form to inject our oocytes. Thank you for your patience. And if any discussion we can do.
Thank you, Dr. Selvam. Thank you so much. It is nice illustration, and I think most of the people get to know so many things from this. I have one question. You told us individually all the parameters like motility, morphology, and million count. If the patient is coming with the around 3 ml count, or count is around 5 million or maybe 4 million, and morphology is also 3 million.
Actually, sorry to interrupt you, sir. I'm not able to hear the voice.
Okay. So you told us about all the parameters individually, like morphology, motility, and million count. So my question is that if patient is coming with the volume of 3 ml and with count of around let's say 4 million count or 3.
Just still volume is low only, sir.
Oh my God. Let me check. Now, is it okay?
Sir is audible to all of us, sir. His voice is clear here.
Yeah, your voice is clear now.
I don't know. Anyway, Nidhi, you can, if you have any questions, so you can ask. And my question is, you can ask him if he able to listen your voice. There is one patient of volume of around 3 ml and count is around 3 million per ml. Okay, and morphology is 3% normal, and motility is also around 30%. So in that case, how he will go about? Will he be able to go for conventional IVF or ICSI or what he will do? Okay. Question is this.
Sir, were you able to listen here?
Dr. Selvam.
Dr. Selvam, sir?
His video is stuck.
I think so, yes. There's some.
There is some doubt. Anyway, you can call Dr. Devan if he is there. We can start with panel.
Okay, sir. So we can take up sir's question and in the panel only, sir. We'll put it up in the panel, sir.
Yeah.
And we can ask her to join there.
Yeah.
So Nancy, please start with the panel.
Yes. So moving towards the next session of the evening, that is the panel discussion on need of routine and extended semen analysis, the diagnostic value of the semen. For this, we have our moderators, Dr. Deven Patel and Dr. Hetal Shukla. Can I have the CVs, please? Dr. Deven Patel is Chief Embryologist, Sunflower Women's Hospital, Ahmedabad. He is Masters in Veterinary Sciences and Biotechnology of Human-Assisted Reproduction and Embryology. Can I have the CV of the moderators, please? Doctor, excuse me. Mr. Suman?
You have to go back.
Yes, ma'am. Yes, ma'am. 1 minute, ma'am. Yes.
Dr. Devan and Dr. Hetal, both are moderators.
Saiti, can you show this?
Ma'am, can you see the CV, ma'am?
Yeah. One. Okay. Thank you so much. So we have with us Dr. Deven Patel. He is Chief Embryologist, Sunflower Women's Hospital, Ahmedabad, and his Masters in Veterinary Sciences and Biotechnology from Spain. Previously, he was working as a regional manager with Nova IVF Fertility. He was also nominated as a mentor in ASHRAE Mentorship Program 2022 to 23. Was also awarded as Hall of Fame for Embryology for the West Zone by ET Healthcare 2019. He has many papers under his name as author and co-author. I welcome you, sir. Now we have with us Dr. Hetal Kumar Shukla. He's Chief Andrologist, Nova IVF Fertility. He was also awarded as Icon of Year Andrology Award in 2022. He is visiting faculty in Gujarat Biotechnology Research Center, Gandhinagar.
So
He
Hetal, you have
authored
to
a
see
chapter
the Hetal.
in a-
Sorry, Nancy. Saiti, can we have the CV of Dr. Hetal, sir, please?
Next one.
Saiti,
Yes.
Yeah, thank you.
Yes.
He authored a book in a series of book publications in collaboration with IVI Spain. He worked for management of nature conservation with United Arab Emirates from 2009 to 2015. I welcome you, sir. And I would like to request our moderators to please introduce our panelists for the evening.
Yes. Good evening, everyone. Is Dr. Deven there?
He'll be joining us soon, sir.
Okay, no problem. So can we have the CV of Charu sir, please? Here is an opportunity to welcome all our panelists today. The first panelist of the panel today is Dr. Charudat Joshi. Can we have the CV of Charudat Joshi? So Dr. Charudat Joshi is a has postgraduated in life sciences.
So 1 second, sir.
I'm sorry.
Suman sir, can you share the CV because
Yes,
slides are
just
moving
one.
away, sir.
Sorry for the interruption. Just 1 minute. Sir, please continue.
Good evening, everyone. So to begin the panel discussion, I take this opportunity to invite Dr. Charudat Joshi, who has postgraduated in life sciences, has a special training in ICSI and IVF from Genk, Belgium, special training for embryo freezing from KK Women's Hospital, Singapore in 2004. Dr. Joshi has done special training in laser assisted hatching from Belgium. Dr. Joshi again has done special training in PGD from Germany, has done doctorate in life sciences in 2018. He is an executive committee member, MP ISAR chapter, executive committee member of MP IFS chapter. He has been past vice president of ACE, past president ACE from 2014 to 2016, and currently medical director of Genes India ART Bank. Welcome, Joshi sir. Welcome to the panel discussion. Can we have the next panelist CV? Dr. Nidhi Singh. So we have another panelist, Dr. Nidhi Singh, who has done her MBBS, MD Anatomy, and DNB, DCE, MNMS, and IMSA. She is senior clinical embryologist in Panacea Hospital, Varanasi. She is assistant professor, PIRA, Panacea Institute of Indirect Interdisciplinary Research and Education Academy, Varanasi. She has a teaching experience of over 16 years, multiple national and international publications in her pocket. She is a team member of IHERA. She is a member of prestigious national and international societies like MNMAS, IMSA, ASHRAE, ACE, IFS, ESAR and IHERA. She has a her field of interests are andrology and cryobiology. Welcome, Dr. Nidhi Singh, to the panel discussion. Next CV, please. Okay, we have one more panelist, Dr. Jairam Chandrasekhar, who has done Masters in Clinical Embryology and Pre-Implantation Genetics. He's a senior embryologist in 49 Fertility Center, currently working as a senior embryologist in 4940 plus Fertility Center, Secunderabad. He has completed his MCE from Aspire, Mysore. He has 3+ years of experience in the field of ART. He has got trained under national and international experts in the ART field, authored few publications, and his credit of author and co-author of few research articles in national and international journals are also there. He has attended several national, international conferences, member of IAS, IFS, ISAR India. Current research collaboration is going on with artificial intelligence in deep learning and embryo selection in ART with Annamala University, Tamil Nadu. His area of interest is male infertility, cryobiology, and pre-implantation genetics. Welcome, Dr. Jairam. Welcome to the panel discussion. He is one more esteemed panelist, Dr. Charulata Chatterjee. She is a senior consultant embryologist, Yashoda Fertility and Research Institute, Secunderabad. If we look at her career synopsis, there are total 26 years of experience in the medical diagnostics and ART field, a top-class experience of last 20 years in the field of ART. Her accomplishments are, she's a faculty speaker, participant at various workshops, CMEs, and conferences, learned from the veterans of ART field like Dr. Hans Ingolf Nielsen, Dr. Patrick Quinn, Dr. Catherine Rakowski, Suresh Katera, Dr. Hobart, Professor Gerhard van der Horst, Mercedes Dadin Lazaro, Dr. James Catt, Dr. Joyer. She has organized many workshops and CMEs. The Journal of Obstetrics and Gynecology, she has many publications, fertility and sterility also, 2 papers, chapters in ISAR, IFS published books and bulletins, abstracts, posters, oral presentations in ISAR, ACE and International ASRE, SRM and EV Spain. Mother of 2 children and lives at Hyderabad with her husband Debasis. Welcome, madam. Welcome to the panel discussion.
Sorry, Dr. Hetal, this CV is old, and sorry, Dr. Charulata, for this wrong CV over here. She is now with 49, and she is a scientific director of 49.
I'm sorry, I was not.
No problem, no problem. It's okay.
Thank you, thank you. So next panelist, CV, please. Here is the panelist, Dr. Dipti Repale. She is MSc, MPhil, PhD, Lab Director of Mohawk High Tech Super Speciality Hospital, currently working with Aurobindo Institute of Medical Sciences, Indore. More than 15 years of experience as an embryologist in India and abroad, teaching faculty for DM and MCH Reproductive Medicine in Sri Aurobindo Institute of Medical Sciences. She is member of ISAR, ACE, IFS, executive committee member of ACE also. Areas of interest in sperm DNA damage, areas of interest in oocyte vitrification and embryo biopsy, presented various papers, posters in conferences, and published papers in peer-reviewed journals. Also, welcome Dr. Dipti to the panel discussion. And now Yoshita's CV, please. Dr. Yoshita's CV, please. Yoshita Tanwar, she has completed her MSc in biotechnology, more than 9 years of clinical embryologist experience, worked as senior embryology and lab in charge, New Life India Fertility Clinic Private Limited, ASRM certified clinical embryologist, certified in advanced skill set embryology training conducted by Merck Center of Excellence in Clinical Embryology, Kasturba Medical College, Manipal, member of ACE India and ASRM Society, and she is a team member of IHERA. Also, welcome Dr. Yoshita to the panel discussion. Welcome all. With this introduction, we will start the panel discussion. As we are running little late, I will start soon. I will start. Yeah, I'll start sharing my screen. So the topic and subject of the panel discussion today is need of routine and extended semen analysis, the diagnostic value of semen. So routinely, lot of discussion has been taken place. Routinely, we have semen, gold standard, cornerstone, everything. We all know routine semen analysis, macroscopic analysis, and microscopic analysis. Now, with the recent 6th edition of the WHO, order is also a part of macroscopic analysis, other than appearance and all. Microscopic analysis also. Fructose test, though it is not routine semen analysis part of, but nowadays maybe it may be coming up as a routine semen analysis. This is just giving an idea of the extended semen analysis. As per WHO, indices of multiple sperm defects is the part of extended semen analysis. Sperm DNA fragmentation, genetic and genomic testing, tests related to immunology and immunological methods, assessment of interleukins and markers of male genital inflammation, assessment of immature germ cells in the ejaculate, testing of antibody coating of spermatozoa, biochemical assay, and assessment of sequence of ejaculate. These are the listed extended semen analysis in the 6th edition of WHO. We will look into some of the relevant and in our day-to-day routine analysis of what concerns us and how best we can have an approach, and our esteemed panelists will give their inputs we will have different cases and we'll try to find out how best we can have the approach towards the patient. Here, the listed case is a male partner who submits a semen sample with a very low volume, say 0.5 or even less. The abstinence may be reported acceptable, which may be around 4 days. Initial drop on the glass slide, if we look under the microscope, may have no sperm at all. Then I would like to have inputs from the panelists. How should we proceed for the semen analysis? This kind of case, I put up questions like how to proceed for the semen analysis, what could be the possible causes of low semen volume, and if it is for cryopreservation, what options should we opt, and how the chronology of ART treatment could be suggested. Can I start with Charu sir, please?
Yeah. See, in this particular case, what we can think of is improper collection of the sample. Probably it is only the initial fraction collected and the rest everything is maybe dropped down or is not able to collect properly. So in this case, my advice to the patient, or we can suggest to patient, is to come again after 2 days or maybe next day and again given another sample. because there is, as this says, that there is no sperm. So we have to be very much sure about the
Yes.
present or absence of sperm. So ideally, we should ask him to give one more sample, and then we can proceed.
Yes, sir. Dr. Nidhi, your
I do agree to sir. So I'll first of all query the patient. Since the volume was less from the beginning, whether there was some spillage or the improper collection is there. Secondly, sir, if the sample is showing no sperm, then we can think that it can be a case of cryptospermia, where the sperms are not visible in normal semen slide. So we can add, because the volume is very less, 0.5 ml. If we centrifuge also, the pellet might be difficult to form. So we can add 0.5 media, 1 ml of media, centrifuge it, take the pellet and take the drops in the slide, 20 microliter drops. Whole sample should be assessed for any sperm under the macro manipulator, and we can search there also if there is any sperm, a dead sperm, anything is there. And definitely, as sir said, we have to call the patient again for a repeat sample, because this sample might be initial only the collection is wrong. So we cannot take it as a sample which will deciding the further patient analysis. Again, repeat sampling is definitely required, sir.
Right, sir. Right. Dr. Dipti, can you give your...
Yes. Actually, the first thing is the counseling of the patient is very important before making the semen analysis. When submitted the sample also, then we have to check out and we have to ask the patient whether there is any collection difficulty or if there is any spillage of the sample. Once we confirm with the patient if nothing is improper, then only we should go ahead with the semen analysis. If there is any problem or if there is any spillage, and we have to first confirm with the patient. And if the patient is not available, he might have something left the sample. Before going for the analysis, first thing we have to check is the pH. If the pH is less than the basic value, like 7.2, then it might not be a semen sample. And if the pH is okay, but still we can't see any sperm changes, then we have to go ahead with the centrifugation and we have to check the sperms. Then otherwise, we ask the patient to come back and we definitely ask him to go for another semen analysis.
Okay. Dr. Charulata, madam, please.
Every point has been covered. I think the first thing is collection error, what we have to see, as Charuji has mentioned. Second, if collection error, that has to be rectified. Third is check the pellet after centrifugation. Add little, warm media, pre-warm media, so that if any sperm is there, and then pellet should be checked. Clinically, doctor can correlate that is it once or any previous report is there, whether this report has the same no sperm or what is that or what was the volume if he has done analysis before, and that patient can be asked to give the second sample for the analysis.
Any idea what could be the causes of the low semen volume? Anybody?
Maybe absence of vas.
Yeah, ma'am, as said, absence of vas difference is the most common.
Yeah.
The absence of ejaculatory duct. CABVT,
Yes.
sir, that we say, so.
Yes.
But some obstruction is there which is preventing the sample volume to come.
Yeah.
Correct. So let's move to the another case.
If I can add something over here.
Yes, please. Yes.
Yeah, sometimes
please.
This sample, that it is very low in volume, 0.5 ml. Sometimes what happened, it is actually happened with me, same kind of patient. He came to our clinic and he gave sample in my other lab. So twice he gave a sample in that lab, but my boy couldn't find any sperm on this in that sample. But that patient is from from other place. He went there. He went for that another sample over there. There was very good count over there in that lab. So twice and thrice it happened. So ma'am called me and told me that patient will come to your lab and you have to check what is the problem? Then I called him next day and I told him, you will get one separate room. You just go there and give me that sample over there with your wife or whatever you want to go with that. And he in the morning came over there and he gave sample, and you know, at surprise what I have seen, that sample was absolutely normal, volume and everything was normal. So sometime what happened that our collection room was just near the waiting area. You know, the patient is not able to ejaculate full volume over there.
True.
And
True,
that
true.
time it could happen that because of that fully reached to orgasm, patient could have that kind of problem. And in our main lab, there was separate room, very you know, in the corner side, nobody can disturb over there. He easily gave the sample and volume and everything was normal. Sometime maybe because of orgasm play the role.
True, true. So incomplete sample ejaculate is also the concern. Yes, with this we move on to the another possibility. Another patient who submits the semen sample with a volume of say 0.3 milliliter, and sperm count and motility is in the normal range, say 60 million per ml is the sperm count and 55% is the rapid progressive motility. How to analyze and prepare the sample for IVF and ICSI procedure, and if the patient is for say IUI procedure, what should we do? So this time, let us begin with Dr. Jairam, please, if you have
Yes,
any idea.
yes, sir. Yes, I'm audible.
Yep, yeah, please.
Yeah. So this kind of, if you see this sample, volume is 0.3 ml. First thing we can previously, all the panelists said, we can go for the second collection. We can, if on the day of IUI, we can ask the patient for the second collection. If volume is coming extra, we can add that volume also, and we can start prepare the IUI. Or else we can, if patient can't able to collect, we can add some HPS media related things, and we can dilute because count is it's pretty enough. So we can dilute the things and we can start the IUI process, or else we can ask directly to the second collections for the patients. Sometimes, as per the Ved Prakash sir told, sometimes patient. We are also showing in my previous IVF center, some patients they can't comfortable to collect the samples. They will come out with the collection area with a lot of sweats and they feel embarrassed. They are asking me very silently like, sir, I can't able to collect, what I have to do. So like we have to give them that privacy and space, so it will be improved. And of course we can ask them for the second collection and we can dilute the samples. We can proceed with the IUI or it's, that's it.
Dr. Yoshita, please.
Yes, sir. I agree with Dr. Jairam because we need the sample. We need the
No audio, please.
Ashwata, your voice is breaking. It's not there.
Yeah. Meanwhile, Dr. Dipti can please.
Of course, we can ask the patient if he can provide the second sample. If not, the count is pretty good and the rapid progress is also pretty good. So we can go ahead with preparing the sample and we can proceed with the procedure.
Yes.
Hello.
Hello.
Sir,
Yeah.
am I audible?
Yeah. You are.
You with Dr. Jairam because
Can I add one more point here?
Yeah, please, welcome.
Yes.
So generally for this case, as count is pretty good, we can go ahead with 0.3 ml of sample also. But generally in my practice, if IVF and ICSI is there and patient, generally we do a semen analysis in our center only. And we see that in that previous semen analysis, which has been done at our center for once or twice, and it has a low volume. So we'll freeze a backup sample, So kind of sometimes it
Exactly.
is oligo or something. So we pool the sample like fresh and frozen.
Yes.
So that can be also done.
That can also. True. Dr. Nidhi, if you have something.
Same, I was going to what ma'am said, because first of all, repeating a sample in your own center by you, especially of the cases who are undergoing ICSI and IVF, is very, very necessary. Don't go by the reports which are coming from outer center. And if it is the same amount of volume, then do keep an aliquots of frozen sample ready, so that you don't land up having no sperms or very few volume. If he's having such a problem of low volume, he might land up into no aspermia also on the day of the pickup. So we have to have a backup. That is important.
Yes. Charu sir, I have one doubt with this kind of sample, that in the laboratory, suppose a newly joined technician is there, and if he waits for liquefaction for this kind of sample, what could be the risk, sir? With a very little volume, and what advice we can give?
So liquefaction, so anyway we wait for 15-20 minutes, but in this particular case what I usually experienced is that if the volume is very low, like 0.3 ml, usually this sample is very viscous. So the second point in this is that the count is pretty good. So I don't think there is anything special needed for this particular thing. We can just add up with some HIPIS media and mix it and keep it for some time and can process as we process with the density gradient for all preparations like for IVF or ICSI or even for even IUI. So double layer gradient method we can use and we can just proceed.
Yes, sir. No problem. No, the possibility.
We should expect viscosity in this kind of sample when the volume is very low.
Correct, sir. But sometimes some novice people can wait, and probably this kind of very low volume can result in drying, very fast drying.
Yeah, but
very fast drying.
Yes. So in that case, my answer will be if someone new join or something, the proper answer for this thing is the SOP, which I always tell in my discussion.
Very true.
That there should
as you
be a
rightly
procedure.
mentioned, media, known quantity of media can be added.
And particularly in these cases, if suppose for diagnostic, when this patient has come and we have seen that this always produce a low volume, probably on the day of case we can give a container with addition of some media already in it. So the liquefaction and other procedure can be taken care.
Very true, sir. True. So hope very good inputs have come. So hypospermia, this kind of cases are called hypospermia, and before we declare azoospermia or cryptozoospermia or anything, this is a workup collection, abstinence problem, repeat semen analysis, psychogenic anorgasmia is there, then refer to the sex therapist. Hormonal abnormality can be one of the reason, and symptoms of hypogonadism is there or not. Testosterone level. Of course, there are certain clinical inclusions are also there in this. So possibility of EDO correction, surgical correction, and possibility of retrograde ejaculate also sometimes with lower volume is also there. So this all things can be considered and can be moved ahead. So obstructive and non-obstructive azoospermia may be the possibility. So poor quality of semen may result from the abnormal accessory gland. In this kind of cases, how fructose twist is going to be helpful? That's the question I would like to have from the panelists, please. Can I begin with Dr. Nidhi, please?
So fructose, especially in the case of obstructive, is very important because it can mark the level of obstruction. For example, sir, when we see the anatomy, when the testis, from the testis, when the sperms are formed, they go to the epididymis, and the vast difference. And there, the seminal vesicles join the epididymis to form the ejaculatory duct. Now, this point of demarcation is very important because if there is any obstruction in the ejaculatory duct, then the seminal vesicle secretions won't come, which therefore the fructose test will be negative. But if there is any obstruction above the ejaculatory duct, that is in the vas deferens, or is there any problem in the testis itself, the sperms are not being formed or the ejaculate is not been formed, then the fructose test will always remain positive because the seminal vesicles are functioning. So fructose plays a very key important role in, especially in cases of obstetric azoospermia, to demarcate. So.
True. So anybody from the panel would like to have comment on obstructive azoospermia or non-obstructive? Charulata ma'am, please. Anything?
No, sir, that is all what Dr. Nidhi said. For us as an embryologist, either it is obstructive or non-obstructive. If we get sperm, it is either from TISA or micro TISA, we should get the normal morphological sperm. In fact, today I had a 2 TZ and yeah.
True. For the benefit of the audience, the lower reference limit of the fructose, if it is carried out by quantitative assessment, then it is 13 micromolar per ejaculate. Let us have a look on a case where a normozoospermic semen sample is inside the laboratory. High amount of round cells is received for the analysis. The male patient is 35 years old. He is an IT professional. He is heavy smoker. He is fond of junk food with BMI of 40. The couple has undergone 2 failed IUI cycles and 3 failed ICSI cycles with low fertilization and poor blastocysts. What workup is advised before enrolling for the ART treatment? This is the question. Can we start with Dr. Dipti this time, please?
Yes, sir. Definitely, I would suggest with the sperm DNA fragmentation. And here, we can't see about the Y parameters because husband seems to be normal. That might be an unexplained infertility. From the Y side, everything is okay. Then SDF is the best option because in unexplained infertility, the rates of higher SDFs are very high, and that clinically related also. They tend to have a low live growth rate and blastocyst qualities are poor.
Very true. Any other input? Yeah, please, ma'am, please.
3 thing has to be, counsel to the patient, though he is young. 3 work style has to be changed. First of all, is IT professional, so maybe he is using the laptop, keeping on a lap. So laptop should be kept on the table. So number 1. Number 2 is he is a heavy smoker, which will add it to the sperm DNA fragmentation, plus BMI is very high. So all these parameters need to be controlled beside giving him all the antioxidants and max and blah, blah, blah. But first thing is lifestyle change.
True.
And sometimes that Dr. Hital, we can use the new techniques are available nowadays, microfluidic kind of things. So they will automatically reduce the DNA fragmentation in the sample. And even frequent ejaculation can also help in these cases.
Correct.
But it is good to go for to check the SDF. You will be able to rule out what is the factor. After these, that you already mentioned, IT professional, heavy smoker, and everything is increase the SDF.
Yeah, everything contributes. Yes.
Can I add here
please.
One thing?
Sir, please.
See, for me, we can go for SDF and we find the abnormal values and all. Ideally, this patient should be referred to a good andrologist, and that andrologist should be given a chance to keep a follow-up of this patient and improve his sperm quality.
Absolutely.
Very true. So when we suggest lifestyle changes, what should be the duration considered? How long the time should be given to the patient when we suggest and counsel?
At least one spermatogenetic cycle if patient wants to stay back, otherwise they will hospital shopping.
Yes.
Exactly.
Yes.
I think minimum 3 months. 3 months time is required to means other than changing lifestyles. Then 3 months minimum is required to regain the potential.
Potential. True, sir. True.
And
So
can
anybody?
I add some points, sir?
Yeah.
Can I add some?
Please.
Yeah, and here we are seeing the patient have a high number of BMI. So between sir said the 3-month duration, they can try to reduce their weight, get into the normal BMI, and that could be the possible way to improve their things. And as per Charmam told, that lifestyle should be changed, including in this also. So that weight should be reduced. So it will also helpful, and then we can go for the DFI. And they should. The patient is a heavy smoker and they must quit the smoking and follow up on taking the healthy diet. Then we can proceed after 3 months, after 5 months also we can proceed. Then we can see the improvement. Then according to that, we can suggest the patient to go for the ART treatment.
Whenever there is a higher SDF, many discussion is about using biopsy sperms. So what is the take of the panelists on this? Anybody can comment. I think
there are many studies. Initially, when STF came into the picture, we said that directly from the production site, if we take the sperm, it will improve. But recently also from our India also 10 years analysis has come, and abroad also, if you check it out, the treated sperm either with max or microfluidics and from the TISA, there is no difference in the live birth rate or any other thing. So it has not added anything which is, highlight that doing a TISA will give the little more improvement in terms of blastocyst formation rate or usable blastocyst or live birth rate. So studies are varies, but the recent study says there is no much of difference. So what we can do is there is no abstinence, means frequent ejaculation, and either if it is we can treat with the max, which gives a very good results, or microfluidics.
You are absolutely right. Actually, I have done many cases of this STF with TISA, and we did many TISA sample, used TISA sample, but I don't find any kind of improvement in that TISA patients. There is nothing much difference in between.
True.
But for practical point of view, can we suggest in second cycle?
Patient will not agree to it. If you tell the patient it is your sperms, he will first find a factor that the oocyte must be the factor, irrespective whatever you say. But 2 failed cycle, yes, definitely we can convince in the 3rd cycle. There might be some problem with the sperm itself. Because first 2 he will never agree. That is the reality, sir.
Dr. Devan, there is a few good techniques are available. And when we show them that these are the publication, these are the research we already happened in the past, and now recently that paper has come and they recently reported there is no difference in between these studies. So I don't know, patient will be agree or not for that. But yes, it depends on the consultant also, how we counsel the patient. So he can go for definitely for biopsy sample.
Right, sir.
Yes. So
but
if Dr.
I
Deve,
try to avoid, because already sample is good, it's coming, and you can use the that frequent ejaculation or MAC or microfluidic technique to improve the sample.
Yes.
Right, sir.
Yeah. So may I request Dr. Deven Patel to take next slide, please?
Sure.
So here I would conclude this SDF part is low motility. It is an established fact that low motility is directly related to the higher DFI. ICSI, IMSI, MAX, FIXI may be the options to minimize the risk of poor ART outcome due to higher DFI. Host can be used to select sperm with intact DNA for ICSI procedure. One of the publications I have come across, they have identified different patterns of host coiling, and pattern D and E is said to be the best, having best DNA integrity. And lifestyle changes can help reduce a higher DNA fragmentation index. So with this case, I would request Dr. Deven to take further.
Okay, so this is the next case where a patient comes out of the semen collection room after trying for 30 minutes for ejaculation. So he is taking like sufficient time and he reports an ejaculation. So now during the conversation with him, it is understood that he has a feeling of orgasm, but no semen expelled. So now the question is what to do if the patient is for either cryopreservation or for regular ICSI procedures. So basically on the day of ovum pickup. So basically, we are expecting some kind of retrograde ejaculation.
Dr. Devin, first of all, like suppose we should see that patient is comfortable or not in that collection group. Number one, we can try to give a chance with nearby if he wants to go to any hotel with the, and then the second is we can give some kind of vibrator or a medical treatment where he can get that. And then if it is a retrograde ejaculation, there is a process how to, retrieve the sperm from the urine, like how you said that alkaline treatment has been given and before the collection. And then we can retrieve if it is a real case of retrograde ejaculation, then we can retrieve the sperm from the urine.
Right, ma'am. So,
and can I add some points, sir? Can I add some?
Sure. Yeah, definitely.
Yeah. We are showing some cases like, patients are, they are really able to collect when we ask them while natural intercourse, they see that sperm is ejaculate. But when they came to hospital, they can't ejaculate due to the environment. And mostly whenever I ask the patient, they will tell, sir, my home is nearby. Can I go and collect? Like we have to give them comfortable. Sometimes they're familiar with their home collection also. So we have to give them a chance to collect. Either we have to, sometimes a patient will ask, I'm comfortable with my wife to collect the sample. So we can give the chance also to collect with them. And whatever the Charu said previously, that is absolutely right. And we can ask them to collect thrice or twice.
Jairam, when you are going to send patient at the home,
it is home is nearby. Either it is home is nearby. If it is
sometimes what happened, you don't know, you never know. Sample is belong to him or not.
No, sir. Declaration consent has to be taken.
Yeah.
Many patient is taken, and we have. I have many declaration samples that brought in, and in that case, even the sample, collection, because when it's a easy corporate center, when are the 6 center, first we have to save our skin.
Yes, you are right.
Yeah, right. Very true. Very
true. Same is with us. We are also taking declaration from the patient.
Absolutely.
But we have to take care of this thing in mind.
Absolutely. No.
Yeah. Rather, I would add declaration from the couple, not only the patient, means both.
Yeah, no, couple with witness.
Yes. Even with witness.
Yeah, even the witness.
Wife should be knowing that my husband is going home and he is taking the collection.
Very important. Very important.
Yeah, it is must, because sometimes husband will tell, okay, I am giving the declaration. It's okay. Like I will sign for my wife also.
Right.
So there are patients, they are really smart. They will tell that, okay, I will sign for my wife. But then I think basically for young embryologist, we can tell that this is definitely very risky. You should call wife and definitely ask her to sign after giving the consent.
Absolutely agree.
Very important.
Yeah.
So any other comment, please? No, I think we can go to the next slide. For retrograde ejaculation, I think Shuklaji, can you elaborate?
Yeah.
Please? Yeah.
Retrograde ejaculate, as everyone knows, sometimes semen passes into the bladder at ejaculation, resulting in aspermia, no apparent ejaculation. Confirmation of this situation is obtained by examining a sample of post-orgasmic urine for the presence of spermatozoa. If pharmacological treatment is not possible or not successful, spermatozoa may be retrieved from the urine. Alkalinization of the urine by ingestion of sodium bicarbonate, for example, will increase the chance that any spermatozoa passing into the urine will retain their motility characteristic. If patient is not alkalinized before the collection, then at the laboratory, the man should be asked to urinate without completely emptying the bladder, produce and ejaculate by masturbation into a specimen container, and urinate again into the second specimen vessel containing culture medium to alkalinize the urine further. Alkalinization treatment, it's of course clinical call, but at least 1 to 2 hours or at least a day prior should be carried out, and then the laboratory should retrieve the sperm from the urine. Dr. Deven, will you please carry forward with case 5, please?
Yeah, so this is the case where a male partner semen sample with volume of 2 ml showing 80 million per ml concentration and normal morphology, so 4% normal morphology. The motility of the semen is 0%. So this kind of sample very rarely we get, but yes, then what are the diagnostic and therapeutic options available with the andrologist?
Sir, we can do horse test for that, I think.
Right. Yeah.
First of all, we should check that when that andrology technician has done the analysis. If it is kept longer time, 2 hours or 3 hours after collection. So the motility will
that
go
is
down.
Also true.
True.
And temperature things also we have to look it out. Either they are keeping in 37° after the collection.
True. Step by step, rule out all the possibilities.
We should make sure the patient has collected without any urine or water contamination also.
And then we can check the viability test by either by using nigrosin or host or anything. And other is a clinical will be andrologist. Can we correlate that? What can be the root cause for the no motility?
Anybody has an experience with pentoxifylline or theophylline using to diagnose?
Yeah, I use theophylline.
So I also frequently use theophylline.
Yes, sir. Charu sir, any input from your side, sir?
No, I have not used theophylline or pentoxifylline. So yes, probably the water contamination we should be seeing, because patient has to be given a proper instruction that he should not wash hands or wash the penis before connection or after collection. So there is a possibility that the sample may get some water, and due to which motility is 0. But I don't have any experience of pentoxifylline or any substance used for increasing motility.
Okay.
But before giving the report, I
Charu,
think,
in case of the 0 motility, what you will do if there is patient sample is like that, or you are going to do ICSI, what you will do that in case?
Then our options are always open. We have horse test. That is the best possible option available to see the vitality, because we are doing it. We are using that sample for ICSI.
If anyone has experience on laser shot.
No, there is a calculated risk in the laser shot, sir. Even if you, reduce the laser intensity, we might damage the head if it is tail is short or something. So instead of that, you can just go for the touch method, where you just add the needle so the coil will be tail. Host is the best option, but I feel theophylline is the best, because if you see that little vibration in the sperm, will be, as an embryologist, you feel that this sperm is live, because again host is little time cumbersome. You have to first host, then you have to wash that sperm and then inject. But here if you add and it is immediately shows the motility.
I think Charmam today also she used theophylline, I think, second case.
Yeah, 3 cases.
Already ready-made medium is available, theophylline.
Yes,
so
yes.
why not to use that theophylline?
And otherwise, there is an option of like Charu is saying that we can feel, means as an embryologist, you can feel the flexibility of the tail. If it is,
With the touch method, that injecting
yes,
needle, if you touch the end of the tail, no, it will automatically curl.
Yes. So it works. Sometimes it also works.
So usually in TISA samples, I have landed up having very rarely I find motility. So theophylline I use it in a drop as a protocol. In case the sample there is no sperms are motile, I directly put it in the drop, the one of the sample, and from there very beautifully I can see the difference.
Absolutely.
Because time
And
is
I TISA sample severe rote, I don't even put PVP. I put the slit of the direct TISA sample, put theophylline, take the sperm and go to the PVP.
Same, ma'am. I do the same
Yeah.
thing. Easy, ma'am. Devin sir, next.
Can we go to next?
So just an idea of vitality, 2 methods, everything we have discussed, vitality test, neosyn, nigrosin, and here is an image which I was discussing, that publication with different pattern of host, and there if you see host pattern D and E, that pattern is considered having the best DNA integrity. And if we are performing ICSI with host positive sperm, this can be considered. Case number 6, Dr. Devin, please.
Okay, so patient is coming for repeat semen analysis and submit semen sample with 3 ml volume and concentration is nil. So his previous analysis was with 0.8 ml volume. So again, it was less, and there was previously also no sperm seen. So ejaculatory abstinence in both the analysis was 4 days. So then how to decide the order of surgical retrieval of the sperm? And also how useful is the fructose test in such kind of cases?
We have discussed a similar scenario earlier, sir. So fructose test, if it is positive, sir, then that means that the obstruction, either it can be, it is not an obstructive azoospermia. So there is some testicular failure, something is there. So in those cases, we have to first get the other tests done for the male partner, like the hormone analysis, testosterone levels, and the ultrasound to see the volume of the testis, sir, whether the failure is at the testicular level or not. And otherwise, if the fructose test is positive, that means there is no obstruction. Again, the same scenario. We have to test the testis. But if there is negative fructose test, that means there is some obstruction. Then we do the physical examination of the patient where we can assess the testis, the volume, and the epididymis. If there is swelling, sir, then we can very well go for the epididymal extraction by PISA, sir, for the semen. So this is how clinically the andrologist, or we can directly refer to the embryologist, sir. Andrologist, they can work up what is the point. Because surgically also there are certain surgeries which claim that the obstruction can be resutured and the canalization can be done, but the success rate is not very good, and the duration of like if the patient is young, he's hardly 18 years old or 25 years old, then he has time to get the surgery done and get the repair done. But if the time is less and the patient is 40 years old, then we have to take other measures, like we can do TISA, PISA, and directly we just need a sperm for doing the fertilization, sir. So this is
right.
So moving on to the case 7, semen sample ejaculate had a 9 milliliter of volume, but sperm concentration is very low, less than 1 million per milliliter, and with a very few motile spermatozoa, and abstinence is say more than 10-15 days. What are the options which can increase the favorable chances for ART outcome? who would like to take it first? Dr. Nidhi, you can start, please. Any idea?
So semen volume high is in cases of when there is infection, the glandular infection is there. So a lot of secretions are there, sir. So it can be prostatic inflammation also, and inflammation from the seminal vesicle, mainly the seminal vesicle. And there might be some, because of the infection, the sperm production is also less. So all these factors are contributing in the current scenario. Thirdly, the abstinence is very long. So if we start from the beginning, first we'll counsel the patient to keep an abstinence of 2 to 7 days. Repeat a sample, sir, and then see what the outcome is to take the different measures. And we can also give a blanket treatment because so physical examination is also an important part. We can refer to the surgeon. If there is inflammation, we can start with antibiotics also. The surgeon will start with the antibiotics, sir. So then again, a repeat sample is must. So this cannot be taken as a base sample for that patient. We'll counsel him again to come back. Ma'am, Charu ma'am can add on to it.
I think you have completed all that points. Yeah.
If patient is came on that pickup day and same scenario.
So 1 million ICSI, sir. 1 million ICSI, sir. Done, sir. ICSI. No problem.
So in that scenario, 9 ml volume. So do you want to prepare whole sample, or you will take some part of that sample?
I to divide the sample and prepare, sir. Don't risk it.
No, but in case when you are suspecting infection, then would you recommend to use frozen sample? Because previously when the patient has given collection while as a backup sample for freezing.
If backup sample is there, then there is okay. Then that is good to use that sample.
No, but like my question is basically this is for
in this case,
like they should think in that line.
Yeah. Because in this case already you mentioned that abstinence was 15 days. So definitely DFI will be high. And you don't know what will the result, what will be the outcome of this sample.
So you can go for a similar sample after an hour, sir.
Or you can ask second sample. Yes, you can ask for second sample.
And even with the suspicion of infection, chances of higher SDF goes high also.
High, yeah.
Yeah. So shorter abstinence may help in this kind of scenario, probably. Let's move on to the another case where a couple who has 3 failed IUI cycles, 3 failed ICSI cycles, male partner gives semen sample with 3 ml of volume, 60% of rapid progressive motility, and morphologically 100% globosospermia is diagnosed. What are the therapeutic options left with the laboratory?
PLC zeta deficiency, artificial oocyte activation.
Exactly.
Dr. Charu is expert for this. He has done so many oocyte activation in the past.
So Charu sir, please share your experience.
Dr. Charu Chatterjee is doing oocyte activation.
Sir, one charu is enough.
So it is always helpful actually. Oocyte activation is calcium ionophore is already available in the market.
Yeah.
So you can use that calcium ionophore for this kind of patient.
Right.
Maybe Jairam or some other can highlight.
Yeah, Yoshita.
Yes, sir. Anyway, I'm under working with Charlada ma'am.
No. He's a very good. He is a very good team player as well as he's excellent, skilled embryologist. I'm happy to be in my team.
Yeah.
Thank you.
Nice.
Just out of this context, I just want to know what is your experience, Charu, with ICSI, without oocyte activation, with ICSI, with such kind of globosospermic sperms.
Sir, first of all, I haven't seen any in my career which has 100% globosospermia, to be very frank. But if I see that most of them are globosospermia, I think because the artificial oocyte activation, the main cause is, for the globosospermia where it has been started, because there the PLC zeta deficiency is high. But now with the advanced technique, suppose once the PLC zeta is available, we can inject the sperm with that and we can ask the gamete only, bhai tere mein kya kharabi hai, bol tujhe bahar se deta hu. I think centrosome or ye. So that can be, that can be a future when our next generation will do that. But still for the globosospermia, I think except artificial oocyte excision, there is no other answer in our lab, because electrical oocyte activation is not very popular and we do not have that kind of gadgets in the lab. So what else has been left? That we are left with only one chemical oocyte activation.
Agreed.
Ma'am, I have seen 100% globosospermia. That was the first thing I saw when I started morphological staining. And the first slide which I saw was globosospermia 100%. I did the patient insisted on ICSI with the same with his sperm. So we did it. It was complete fertilization failure. We landed up into that. And then again the second cycle. But when we went, then he went to all the research. He said we did the analysis also, the gene analysis also. So he had the problem. So he opted for donor sperm, ma'am. It is not an option in our lab, but that is one thing. But the patient himself said, I don't want my child to have that. Seeing the research article, even though there's no proven thing that the same genetic problem will go to the child also, but the patient opted for donor sperm.
Maybe in first case, maybe in the first cycle only, if the counseling has been done and if he has done with the sibling oocytes, half of the artificial oocyte exhibition and few, then probably seeing the blastocyst, he has something in, when he has nothing in hand, we'll definitely go with the donation.
Yes, ma'am.
And one more important concern I would like to share here is, looking at to the cycles patient has undergone. See, many cycles of IUI, many even ICSI cycles also. The real case we have experienced is many places the diagnosis, morphological diagnosis was towards normal. Many means lot of normal percentage was given, but in fact it was 100% globosospermic, and that's where the correct diagnosis of globosospermia is also a very, though it is very rare, it is really an important concern among the laboratories.
Nowadays, teratogenic index is increasing in male because of this lifestyle. So teratospermia is really increasing. Most of the patient or couple are landing up into male factor more. If we actually do a current data, if we share the data, all of the labs, we'll find that as. So this is what we are facing at our lab.
Yeah, it is true. So here is just globosospermia, and one important thing people mix up with, maybe possibility of mixing it with the pinhead, is if the basal plate fails to attach to the nucleus of the opposite pole to the acrosome at spermiation, the heads are absorbed and free tails can be seen. This cannot be counted as head defect, and it should be reported separately in relation to the head structure. So genetic and genomic testing based on, here the question is based on routine semen analysis, when to offer genetic screening of male partner. This is the question. If someone would like to come forward. What would be the possibility after looking at to the semen analysis, spermiogram, and then say go for the genetic screening?
Genetic screening is usually again the same scenario. So when there is obstruction, CBVD, you have to rule out what are the chromosomes which are involved, or what is the genetic analysis. So is it complete or is it partial? So that time is one of the scenarios where the genetic analysis is important. Secondly, again,
Even multiple failures are there. If
Yes,
multiple failures are
recurrent
in a
abortions
history of
and
failure,
recurrent
then
abortions.
definitely
frequent abortion, recurrent miscarriages may be the reason.
And if you find there is no abnormality in the female, then definitely you have to rule out what is the main reason for that.
Sir, shall I add a point here?
Yeah, please.
Since the question is based on routine semen analysis, in our practice, we see if we see poor morphology, in that case, we do SCD or other DNA fragment test. Because that is for multiple failure or other things is different. But based on this question, based on routine semen analysis, if you say, then we'll see the morphology like megalo or poor normal heads like that. Then we go for SCD test usually.
Globus sperm is again an indication where you need to see.
Yeah.
Can I add some points?
Yeah.
Yes, sir. So it is based on the routine semen analysis. Anyway, before we can take the patient family history, either the male partner, their family have any genetic abnormality in the grandparents or anything, or their own sibling, their child have any issues related in the genetic related. So that things we can consider on the one of the point. So we can proceed the genetic testing for that thing. And moreover, the physical, sometimes the male with a non-sexual secondary sexual character is not there, or something, it's looking different. Then we can assess the physical assessment. Then we can proceed for the genetic testing. This is also one of the point to be considered.
Right. So to conclude this genetic part, abnormal levels of aneuploid sperm are most commonly observed in men with spermatogenic failure, oligozoospermia or oligoasthenozoospermia, and even normozoospermic men who are partners in couples with recurrent pregnancy loss may be referred to karyotyping, fish, or anything. Probably today's last case, a normozoospermic semen sample showing more than 50% agglutinated sperm. How to deal with the patient and semen sample for either cryopreservation or IVF ICSI. So, anybody who has really experienced agglutinated sperm and the procedure and their experience, how can we go ahead?
So you know that it is very simple. You can use double density gradient method and you will get the sample, good sample. This is the very simple thing. If you want to do a preparation for cryopreservation or IVF ICSI. But if you want to ask me for the treatment, then definitely you have to go for some anti-sperm test to rule out that it is because of infection or maybe because of that immunological disorder. You have to check for that too.
I would like to add one thing here. This clinical part and density gradient, that is the gold standard method for preparing the sample. That's okay, but one should really be able to differentiate between agglutination and aggregation. That is very important during semen analysis. You see clumps of sperm many times, which may be due to mucus fiber attachment. So whether you have to be very much sure whether it is really an agglutination or clumping, then you can proceed accordingly.
Yes, sir. Yes.
No, and another thing is, this is if it is head to head or tail to tail, head to tail or mix, this is a grade 3 agglutination as per WHO 2020. If it is more than 50%, the simple method for this kind of semen preparation, what I do is I take that 5 ml syringe needle, and I'll pass the semen sample from that instead of adding some enzymatic treatment, which is not advisable. If it is only for analysis, we can add trypsin or something, but if it is used to be either IVF or ICSI, it is not advised to have adding any, enzyme for the, then we can probably add little warm media and pass it into the needle. So most of the time it is very useful before double density gradient method.
Yes, 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 yes.
Has anybody faced some global agglutination, the whole complete agglutination or something like that? I have never seen such a sample, ma'am. Minor agglutination aggregation always
No,
done.
minor, moderate,
Very,
moderate,
very
always.
minor.
Yeah, moderate.
Moderate.
We not not ever faced that part.
Very true. Okay. So vitality, we have discussed. The one general question is if someone has an experience of high hyaluronan binding assay, to share the experience if you have some experience. Is anybody practicing HbA testing?
Not now, before I have done.
But this is not usually done in the routine, sir, because
Yeah.
we don't need it. Actual thing is that there is no scenario which cannot be overcome by the density gradient or the requirement of, we can go to ICSI, which is the easiest thing nowadays. One sperm, one egg solution, problem solved. It is easy to explain to patients also, because doing an IVF in such patients also is difficult to explain to them why we got a fertilization
Directly
failure.
you can use PIXI.
PIXI, yes.
PIXI.
That is,
Yeah.
So I have been using both, sir, PIXI and ICSI. I don't think so. There was much difference in the result.
Any difference, yes.
Outcome. There was not. Even the
You
research
know,
article says the same.
But the Cochrane review says that this is the all of the add-on. This is the best thing to use.
Absolutely. So many ICSI we have done. I think our eyes has become like an IMSI.
Yeah, you are right.
We
You are
pick
right.
up
Absolutely
the.
right.
Yeah. So anyway, high hyaluronan binding assay is based on the principle that is used to evaluate the sperm maturity through assessment of the binding capacity of its head to the hyaluronan. HbA is associated with fertilization rate, pregnancy outcome, and DNA fragmentation. Possibility of DNA damage is more frequent in the immature motile sperm than mature motile sperm in asthenozoospermic patients. HbA identifies mature sperm, and hence the possibility of selecting the sperm with intact DNA is also higher. Low motility of the sperm is indirect indicator of higher BFI. So when good motility sample is there, HbA may predict the maturity. Here is just a sample showing the HbA bound spermatozoa diagnostic purpose. With this wonderful panel discussion, we come to the end of the panel's discussion today. The take-home message for today's panel discussion may be routine semen analysis is aimed to prioritize the line of ART treatment. Low semen volume and countable sperm can be optimized for the ART treatment with semen vitrification as well. Globosospermia, though it's very rarely found, needs to be correctly diagnosed. Apart from basic semen parameters, count, motility, and morphology, BFI, HbA, and oxidation reduction potential testing is also available as advanced diagnostic tests. Max PIXI IMSI can be opted on the basis of the spermiogram detailed with advanced diagnostic tools. Thank you all the esteemed panelists for your very valuable, very experienced inputs on the many kind of scenarios, practical explanations. Thank you very much to one and all on the forum. Thank you.
Thank you. And
Thank you.
sorry, Dr. Hetal and Dr. Devan, actually, this topic is very near to me, and that's why so many times I'm jumping in this.
Oh, no, it was wonderful. This
But
was
it
a
was
discussion.
wonderful. Yes.
So
Yeah.
wonderful.
So many things we have learned. So Dr. Charu, we can go for vote of thanks.
This is a wonderful thing which I always do. So, on behalf of HIRA, I would like to thank all the participants, all the panelists, speakers, and our audiences for making it an memorable event. And we learned so many things about semen analysis. Still, semen analysis is a very first and very basic and very primary kind of evaluation to be done for any infertile couple coming to the patient or coming to our center. So with this, once again, on behalf of IHERA, I thank all of them. And I would like to mention here that IHERA is coming up with skill development workshop on advanced micromanipulation. And this is supposed to be planned from 14th to 16th April. So just for your information, keep your dates blocked for this. We'll come up with the further details soon. So over to Nancy, Nidhi.
Thank you to all the panelists, all the moderators, all the conveyors, and have a good day, sir.
Thank you.
Thank
Thank you, everyone.
You can stop the
Thank you,
sharing.
Samta.
It was a
Dr.
very
Suman.
informative session.
Yeah. Thank you, Dr. Suman, and thank you, Shield, for sponsoring this program. Thank you so much. Thank you, everyone.
Thank you all.
Thank you, Ved Prakash. Thank you.
Thank you.
Thank you.